Good morning, everyone. Thank you for joining us today, both to those of you listening in and the members of our firm who are with us in person. As many of you know, our firm has hosted numerous webinars in the past, but believe it or not, today is the first day that we have a live audience in the room as we broadcast the webinar. For those in the room, you're witnessing Berlis history, and for those on the air, we hope your experience listening in is as smooth as usual. If you do have technical issues, please email the streaming network or call or email the number that is on the invitation. By way of introduction, my name is Andrea Skinner. I'm a partner with Berlis, practicing in our firm's Municipal and Land Use Planning Department. I'm also our firm's Diversity and Inclusion partner and the chair of our Diversity and Inclusion Committee. In this role, and with the committee's assistance, I'm responsible for developing and implementing firm strategies around diversity and inclusion initiatives. I also serve as a confidential resource and advocate for lawyers and staff in respect of diversity, inclusion, and equality issues. I'm relatively new to this role at the firm, and some of you will know my predecessor, Corinne Kennedy, who was instrumental in initiating our firm-wide mental health strategy, something that we continue to review and build upon, including through educational seminars like today's presentation. I'm very proud of the partnership our firm has with Women's College Hospital. This is the 4th year in a row that we've hosted a webinar in partnership with Women's College. I'd like to extend a warm welcome to our panelists today, Dr. Jennifer Wyman from Women's College Hospital, and my partner, Lorenzo Lisi. Dr. Wyman is a family physician at Women's College Hospital, a staff physician and addictions specialist with Women's College's Substance Use Service Addictions Medicine program, and an assistant professor with the University of Toronto's Department of Family and Community Medicine. She holds a master's degree in public health and has a special interest in educating physicians, residents, and medical students about the management of addiction and harm reduction within a primary care setting. She is academic lead for the Opioids Clinical Primer, an online learning program designed to help Canadian health professionals better understand their role in the management of the ongoing opioid crisis. Her primary research interest explores improvements to pathways to care for people living with addictions. Lorenzo Lisi is the leader of our firm's workplace law group. He's practiced exclusively in the area of labor and employment law for over 30 years, representing employers in all areas touching labor and employment law, both provincially and federally. Lorenzo writes and speaks extensively. He's the originator of the Berlis Workplace Law webinar series, which provides one-hour webinars on current and topical labor and employment issues, and which offers practical advice and tips for employers in navigating the complex laws and rules of the workplace. In terms of the structure of today's program, Dr. Wyman will make a presentation on identifying and managing addiction in the workplace. As part of her presentation, Dr. Wyman will describe some of the resources available through Women's College Hospital, including the rapid access addiction medicine clinics, low-barrier walk-in clinics that patients can attend to get help for a substance use disorder without an appointment or formal referral. Dr. Wyman's presentation will be followed by a presentation by Lorenzo on some of the legal considerations and challenges associated with addressing mental health in the workplace. Lorenzo's presentation will be followed by a panel discussion and an opportunity for questions and answers from the audience. If you are listening online, you can submit a question for the panel at any time during the presentation. For our colleagues in the audience, you can feel free to ask questions when the time comes. With that, I will turn it over to Dr. Wyman.
Great. Pardon me. Thank you so much for the opportunity to be here. It's really a pleasure to get to speak with this group and to know that there's a level of interest out there. I hope what I can do this morning is help to frame addictions in a way that allows you to relate to them, perhaps to have a little bit more understanding or empathy for your clients, for people within the workplace, your colleagues, maybe even a little bit more compassion for yourselves. And I'm happy to take questions at the end. One thing I will say, you'll hear me try to use the word substance use disorders as opposed to addictions, and I hope you don't catch me actually using the word addict. Addictions is the sort of term that's been in use for a long time, and the current sort of best practice term is substance use disorder that recognizes addictions as a chronic health condition within the realm of other mental and physical health conditions. So I thought I would frame our talk by trying to present two different cases, people who you might recognize. The first is Carol, a 54-year-old HR manager who's a mother of two, One of her kids has some disability issues. And Carol had some issues with depression when she was in her 30s. She had a little bit of time off work to help manage that and regrouped. In her younger years, she drank sort of in the ways that most people do. She drank weekends in university, weekends with her friends. May have escalated through the Wednesday night book clubs once a month. And then a couple of glasses of wine as she's preparing dinner, a couple more glasses after dinner. And it's increased over time to the point where she's stopping at the LCBO every day on her way home. She not only has her couple of glasses of wine through the evening, but she's got a bottle of scotch that she's going through every night after she puts her kids to sleep, and her husband to sleep, actually. And that's how she falls asleep and gets up in the morning and does it all over again. And she knows that this is not sustainable. She knows that she's constantly anxious, worrying about when things are going to fall apart. But the alcohol is actually the one thing that she finds helps to manage her anxiety. And this goes on until some innocuous event triggers an absolute meltdown. She's mortified by her behavior, and she's encouraged or mandated perhaps to seek some help. So our other case is Steve, and Steve's issue is painkillers. He was prescribed painkillers originally for knee and back pain. He was played hockey at a very high level, and originally his family physician treated him with opioids for pain. But around 2017, a set of guidelines were issued which were perhaps overdue, but really shifted the landscape in terms of pain management in the medical world. And a lot of doctors decided that it was time to adjust their prescribing pattern, some with very good reason, but some actually stopped prescribing opioids altogether, leaving their patients without necessarily having a lot of other good strategies. So Steve began going to walk-in clinics to get medication. When he couldn't get meds from the walk-in clinics, he was running out of them. They started to recognize him. The pharmacy started to question him. He actually started buying pills from people that he knew. That is way more common than you might expect. And at some point when he bought pills from someone, that person suggested that he would actually get a much better hit from it if he injected. Showed him how to use needles, showed him how to do it the first time, and now Steve is in a panic. He never, ever expected that his prescription for Percocets 5 years ago was going to lead him to be injecting. So, of course, he's now depressed, he's anxious, he's in pain, he's feeling lousy all the time because he's either in pain or he's getting withdrawal when his opiates are wearing off. And withdrawal is one of the worst things that someone experiences, and it's the dread of withdrawal that keeps them using. When it comes to opiates, it's a sweaty, crawly, achy, unwell, anxious, agitated feeling that's just will drive someone to do just about anything that they can to avoid it. So we're going to try to speak a little bit about what addiction is, how it develops, and how it can be treated, and how we may be able to support employees in the workplace. So what is addiction or substance use disorder? Recognizing that there are many different substances that can contribute. And just as a note, I'll be talking about substances. There are addictions to, there are behavioral addictions, gaming, sexual addictions, which are not what we're talking about and certainly not my scope. So addiction can be considered a primary, chronic, neurobiologic disease with psychosocial and environmental factors influencing its development and manifestation. So what does that mean? It's chronic. It's something that develops gradually over time, and it persists over time. There's no 21-day program that is a cure. It relapses and remits. Neurobiologic means that it actually is a disorder of the brain that's related to chemical changes, developing tolerance to certain chemicals that ultimately change the way the brain responds and creates pathway shifts that put someone at risk over time. Even when they've been abstaining from a substance for a long period of time, they can be triggered very easily to go back, if they're exposed to a substance or to triggers, to sort of relapse to that use repeatedly. And psychosocial and environmental factors can increase the risk of a substance use disorder or addiction developing, but they also are impacted. So obviously, once someone develops a disorder, it impacts their mood, it impacts their relationships, and it impacts multiple aspects of their lives. So how does addiction happen? The common pathway that we talk about is a neurotransmitter or chemical in the brain called dopamine. So this is your little neurobiology lesson. So dopamine we talk about as being the brain's feel-good chemical. And dopamine gets released by all kinds of good and healthy behaviors, good food, good company, exercise, sex. But substances that are particularly addictive are so because they trigger a very rapid release of dopamine. And so that flooding of dopamine and the flooding with the good feeling creates the reinforcing effect of the substances, because that euphoria, the relaxation, the release from anxiety, all of that good stuff is really appealing. Probably most of us have experienced that at certain times and wanted more. With repeated use, we develop what we call tolerance. So if you can think about when you might first have had a couple of drinks when you were younger, you got a nice buzz off one or two, but as you've moved along, you might not feel any buzz or reaction from that, and you can tolerate 3 or 4 drinks before you get that pleasurable response. Well, what happens over time is if someone uses a substance repeatedly, not only do they become tolerant, but that becomes their norm because of shifts in the chemical homeostasis in their brain. And so without that substance on board, they actually develop very unpleasant withdrawal symptoms, and then they become sort of triggered to continue using just to maintain the normative feeling rather than to get the pleasure. The pleasure actually is gone, and the use becomes what we call sort of compulsive, and people continue to use despite recognizing the many consequences that may be appearing in their lives overall. So no one chooses, no one starts out using a substance thinking that they would like to become dependent on it, but it represents a continuum that maybe we can think about from sort of drinking in your teens or your university years, including potentially drinking in ways we might consider not healthy, right? Binge drinking on the weekends, but you can kind of put that aside, to drinking in riskier ways, to drinking in ways that become more and more problematic or compulsive. So in medical terms, we use something called the DSM-5, the Diagnostic and Statistic Manual. We have 11 different criteria that we sort of, look at to tick off, and if someone meets 2 or 3 of those, they have a mild substance use disorder, 4 or 5 is moderate, and 6 or more is severe. But I would suggest the easy way to think about it is something that we call the 4 C's. So when someone experiences cravings, when their use is out of control, in other words, they know that it's not good for them, they keep thinking that they should cut down and making little deals with themselves, but they're not able to rein in their substance use. When they're using in compulsive ways, so that might be, for example, injecting, using in risky situations such as drinking and driving, roofers who use before they climb up on the roof, and using despite consequences. So despite knowing that your job is on the line, your relationship is on the line, your kids are on the line, feeling unable to control that. And just to note that this doesn't have to do with the amount that someone is using, and it doesn't have to do with the specific substance that someone is using. And as we said, these could apply to behaviors as well as substances. But when someone meets those 4 C's, that's when we call it an addiction or a substance use disorder. So what makes someone more or less prone to developing an addiction? Well, there are certain risk factors, hopefully balanced by protective factors in the best case scenario, and obviously environmental factors or triggers. So some of these won't surprise you, I think. Family history actually represents about 50% of the risk for developing an addiction. We're very sort of interested in what it is about that, but it seems that people are predisposed genetically to respond to certain substances in certain ways. And we see that there are people who feel sick with alcohol. There are people who get no pleasurable effects. One of the sort of medications that brought that home to me was Percocet. Some of you may have had that. We call it oxycodone, oxycodone. Some people feel absolutely ill and awful when they have their first experience of Percocet prescribed for pain. And for others, it gives them a feeling of well-being and warmth and all is well with the world that they don't experience at other times. So that's a genetic predisposition, which then can be compounded by a number of other factors. So we know that men are more at risk than women of developing addictions. Age of starting a substance, so younger age, of course, is associated. We could talk about cannabis later on if there's time to discuss that. The environment in which someone grows up, so what the attitudes are within the prevailing community, what the access is, within the family and within the broader community overall. And then there are a number of psychological factors. So again, some of those are things that may be considered personality traits, risk-taking, for example, but mental health disorders, depression, anxiety, bipolar disorder, post-traumatic stress disorder, and interestingly, attention deficit disorder, which is a risk factor for all substances, but particularly for the substances, for coke and crystal meth. And that may have to do with impulsivity as being part of built into that condition. So in addition, some risk factors you may not be aware of. Chronic pain, which affects 20% of the population, is a recognized risk factor for addiction, both for opioids but for other substances as well. Being prescribed opioids for chronic pain increases the risk of dependence and addiction to opioids, but also to other substances. And trauma is something that is really becoming much more recognized. And when we think about trauma, I'd like to encourage you to think about it as something that exceeds an individual's ability to cope. So I think classically people have imagined post-traumatic stress disorder or PTSD as being something that happened in the most sort of intense exposure to violence, someone who came back from a combat situation, physical assault or a sexual assault. But trauma can also include being witness to violence perpetrated against someone else or exposed to chronic and severe stressors. And one of the types of trauma that we're increasingly aware of is a category called ACEs, or Adverse Childhood Experiences. So these are things that a child experiences or observes that have a profound and compelling, long-standing impact on their development, not just emotionally and psychologically, but even biologically in terms of responses to stress over time. So you could imagine that a child who's exposed to physical or sexual abuse, or is exposed to someone in their family being abused, has issues with developing healthy attachment and relationships. Chronic exposure to stress actually shifts the overall hormonal response to stresses in our bodies and creates sort of the perfect storm for someone to then potentially use substances in ways that may help to mitigate their stress experience. We talk about self-medication, for example, and risk-taking behavior. So what's interesting is that about 90% of adults, think about this room, have one adverse childhood experience as part of their own background. About 90% of those who have one have two or more. And having three or more adverse childhood experiences increases the risks of all kinds of health conditions, not only substance use and risk-taking, but affects everything including cardiovascular health, right down to early mortality overall. So why do we not all have addictions? Fortunately, some of us have resilience, and that really helps to mitigate the effects of stresses and risks. So resilience can be understood as that ability to bounce back, to cope with stress, to not feel like everything is the end of the world when something happens. And resilience is a combination of probably an inborn strength or trait, but actually can be built and developed over time. And that happens not only through family connections, but through community connections. And a healthy, strong bond with an adult doesn't have to be a family member. It can be a coach. It can be a religious member. It can be a teacher. That can really be stabilizing and help to build resilience in a young person. And of course, participation in meaningful activities, whether, again, that's religious activity, an artistic endeavor, a sports team, can be very important as well. I just want to mention, going back to ACEs for a moment and the idea of trauma as being a risk factor for developing addiction, that helps you think about why some communities may be particularly at risk. And think about the Indigenous, First Nations, and Inuit populations in Canada. When we think about the chronic trauma and the legacy of trauma that they've endured. And that's a place where this notion of cultural connection and identity is really important, because it's reconnecting with culture. That's a very important element of treatment. as opposed to our sort of other modalities that we'll talk about. So I see people one-on-one. We're thinking about what's the impact with respect to our sort of country and economy overall. It's huge, so $38.4 billion in costs to the Canadian economy, the vast majority of which is lost productivity, not the healthcare system. Obviously, there's a tremendous amount of money that's expended in the criminal justice system, lots through healthcare, and then that additional sort of direct costs, which may be motor vehicle damage, fire, workers' compensation, and a variety of other issues. And the greatest cost comes from alcohol. That's the graph to your left, with respect actually to lost productivity and not related to healthcare. Interestingly, with respect to tobacco, the greatest proportion of that cost comes from healthcare because of the many impacts of tobacco, not only on smoking and lung-related diseases, but with respect to the many cancers and cardiovascular, so heart and stroke-related issues that tobacco impacts. If you look to the next little bar over at cannabis, the blue is the criminal justice costs related. So we've spent a lot of money on sort of charging and incarcerating people. That's one of the primary reasons, of course, that cannabis was legalized overall, as well as the fact that none of that was working. And then opioids, I'll just touch on briefly because none of us can be sort of oblivious to the front line or front page news about the opioid crisis overall. But I'm happy to talk about that. Again, if we have time, I think well, I'll leave that for there. So the top 5 substances used by Canadians, alcohol, of course, is number 1 across the age span. We have the highest rate of cannabis use of any country, as far as I know, certainly of the industrialized countries overall. But that still means that on average, only about 15% of people are using. And I would say if we think about how people are using alcohol, again, think about that continuum from very low risk or occasional use to potentially at risk to problematic use to alcohol use disorder. Probably 60% of people use in low-risk ways. Another sort of 15 or 20% use in ways that could put them at risk. And then it's only about 5 or 10% that move on to actually developing alcohol use disorder. So what is recovery? Well, recovery looks different for different people. And the paths to getting there are different for different people. For some people, recovery means abstinence from the substance that they've used. That's certainly the model many of us are familiar with from AA, thou shalt never drink again. For others, recovery means being able to use their substance in a healthy way. But I would argue that the most important part of recovery is function. It's re-engaging with family, with work, with friends. It's being able to achieve a quality of life that's been lost when the substance use really sort of subsumed everything else. And focusing on that really helps people overall. So there are different pathways to recovery. Of course, I'm a clinician, so I'm going to speak about the clinical pathways. But non-clinical self-management, that suggests that there's a process called natural recovery, whereby about 20% of people just find their way to recovery over time. They decide that they're going to stop. Things in their life may change. They might find connection to someone within their community that helps things to shift over time. Within what we describe as treatment, there are medication-assisted treatments or pharmacologic treatments, and then non-pharmacologic treatments, and some of those are formal, such as psychological therapies. There's an alphabet soup there of CBT, which is cognitive behavior therapy, dialectical behavior therapy, and acceptance and commitment therapy. Obviously, 12-step programs are things that many people have heard of over time. I'll put a little bit of a sort of caveat. I think there's historically been the sense that what treatment should look like is either going to meetings or going to rehab. And there's actually, although residential treatment can be very helpful for some people, there's actually not a lot of very strong evidence when we look at trials overall for the benefit of residential treatment in terms of sustained recovery. Anyone can go to a program for 21 days or 90 days and do great while they're there. They're in a safe, supported environment. They are away from their triggers, the people, places, and things that are associated with substance use. But that doesn't necessarily translate to sustained recovery. And that transition back to home and the general triggers is a very challenging area. So a really under-recognized area, even within the medical community, is the benefits of medication, both for treating alcohol use disorder and for opiates. For alcohol, we can help people to manage their withdrawal. Again, I mentioned withdrawal is a prime trigger for people to go back to using their substance. And withdrawal isn't over in 24 hours. It's something that lasts for a prolonged period of time at a less intense level and can continue to put people at risk for relapse. And for opioids, so whether those are the kind of street opioids that you hear about, hence heroin, fentanyl, and the powders, or prescription opioids that people may be using, medication-assisted therapy is our first-line treatment and has the strongest evidence for keeping people stable. This is a long process. Some people would say that it takes an average of 5 attempts to quit or to, let's say, to engage in the recovery process as people move through the stages of change from sort of pre-contemplative, we call it, not even being ready to think about it, to contemplating making change, to actually preparing and taking the action. And then the longest period of this recovery process is maintenance. So as we've said, it's easy to detox. It's not easy to maintain the changes over time. And that process really requires sustained support. Probably the best combination is both medication-assisted support and the supports of various groups and counselors to help really enact those changes. So what can employers do? I think, looking at the workplace culture, looking at activities within the workplace, supporting treatment, and looking at the resources that you can provide to your employees overall. So stigma is something that is really pervasive throughout society, and in fact it exists within the medical community as well. One of the things that we really work hard at is trying to change the language overall. And you can imagine if you're someone who's walking around dealing with addiction, you're already carrying shame and guilt and anger and hurt. And to hear people using the terms alcoholic and junkie and clean and dirty, even if they're not being applied to you, but the prevalence of those terms within the common language just really reinforces all of that negativity. And people internalize that. We call that stigma, when they feel that they themselves are not worthy. The stigma within the medical community has actually impacted our training. And so one of those things that delays access to treatment and recovery is, in fact, the lack of education around what to do with people who have substance use disorders. And so that's one of the areas that we're really working on as well. One of the things that I think is, there are 2 things I think are really important. One is recognizing that people need time. They need time to find the right resources. They need time to attend appointments. They need time to go to meetings. They need time for self-care because they've been managing their stresses in obviously unhealthy ways over time, and they're going to have to relearn those behaviors overall. One of the things that I find really interesting and challenging is the number of work-related events that center around alcohol. And I would encourage you to really think about that. I work with someone who works at a sports broadcaster that shall be unnamed, and Friday afternoon, the beer kegs come out. And how is someone who's dealing with a chronic severe alcohol use disorder supposed to navigate that Friday afternoon in the office week after week after week? So all of us could use a little bit of a reminder probably about what Canada's low-risk drinking guidelines look like. And that doesn't mean that's the recommended number of drinks. That's the recommended maximum number of drinks. Right. And I'll just remind you that a tall boy is a pint is not an actual beer. That's 1.5 drinks. So
you're splitting hairs, Dr. Wyman.
10 drinks a week for women and 15 for men is considered a safe upper maximum. Of course, we don't suggest you consume those all on one occasion. And those limits come from what we know about the long-term health risks, even for people who never develop an alcohol use disorder and think that they're drinking in safe ways. Drinking too much at any one time, of course, puts people at risk for making decisions that they may regret the next day. But we're also thinking about the long-term risks in terms of liver. Alcohol, you may not know, is associated with 30 different types of cancer overall. One of the ways I find most compelling to get women to cut down on their drinking is to discuss the increased risk with breast cancer. And for all of us, the increased risk of cognitive impact, not just the day after drinking, but potentially with respect to dementia overall. So back to Carol really briefly. Carol obviously had some risk factors. She had a background history of depression. She had some family stresses with respect to managing her kids, her family, and her job. She's got ongoing anxiety, and she's managing it in unhealthy ways. She started by perhaps enjoying it and using to manage the anxiety and the sleep a little bit, but she's no longer at a point where she is in control. There are some consequences. She came to us. We would assess whether she needed some medication to help manage the withdrawal symptoms and whether that could be done as an outpatient or as an inpatient. We'd be looking at medication to try to help her manage her cravings, and we'd really be looking at her underlying mental health, her anxiety and depression issues, and encourage her to achieve some stability through her self-care, through attending some meetings and some counseling. For Steve, again, risk factor we talked about is chronic pain and being prescribed opioids to manage his chronic pain. And of course, he developed some tolerance, then he developed some withdrawal, then his use really got out of control when he started buying and putting himself in really unsafe situations. He's developed some consequences. And I would say that for someone who has an opioid use disorder, detox alone without any follow-up medication is a bad idea for many reasons. The risk of relapse is high. The risk of overdose is high if people withdraw from their medications and then go back to using, having lost tolerance. So at Women's College, very briefly, I feel very privileged to work with a great group of clinicians, physicians, as well as addictions counselors. We will see any type of substance use disorder and assist with trying to make an appropriate treatment plan. As we mentioned, helping people to reintegrate. We see patients from referral through their primary care providers, self-referral, and we provide what's called a RAM, a Rapid Access Addiction Medicine Clinic. That means that 3 days of the week, Monday, Tuesday, Thursday, between 10 and 1, I'll put in that plug, anyone could actually walk into the third floor of Women's College, see a counselor, and receive a brief intervention. We might not be able to solve everything within that first encounter, but we will be able to bring them back and to make a plan. So addiction is a chronic disease. It's going to take a lot of long-term care and understanding. Please, if this has sort of triggered any thoughts for yourselves around childhood experiences, around trauma, around substance use, and things that have sort of brought some stuff up for you, please make sure to look after yourselves as well.
Thank you, Dr. Wyman. That was very helpful from an employment perspective. I'm going to talk a little bit about the employment side of things from a management perspective, how employers deal with particularly addiction issues in the workplace, and a lot of those, particularly the case studies that you looked at, these are probably pretty illustrative of employees that actually go to work day to day that employers have to manage. So I'm going to start with the prospect that I'm not going to go through a lot of this since Dr. Wyman did a very good job on that, but I want to talk a little bit about the framework, and then we're going to talk about how employers have to deal with this. Let me start by saying this. Employers want to be good, right? You get a lot of information out there that, employers are being discriminatory, they're not treating employees properly, particularly in this space. There's a lot of bad press for employers. You have to understand, too, that when you're dealing with, particularly with addiction issues, there is information that employers don't know, don't understand, and have to manage within the context of having a productive environment. So you're dealing with managers, supervisors, coworkers who oftentimes don't have the training or the understanding of what addiction can cause in the workplace, what the symptoms are, or ultimately what it means to the people, not only the person who is suffering, but the people around them. So there's a collision between health and the treatment of mental health issues, which an addiction is is deemed a disability under the legislation. And I've got a slide there that talks about the fact that disability is very, very broadly defined. Under the Human Rights Code, it's broadly defined. And it means that kind of any degree of mental impairment is a definition that the Human Rights Code uses. All right, which means that if somebody is suffering from a mental disability, that also constitutes a disability, no different than if somebody has a bad back or a bad leg or simply can't work due to physical restrictions. And I think that's one of the big things that employers need to understand, and what we're seeing in the last 5 to 10 years. We're talking earlier on about 10 years ago, there would not be 5 years ago, there wouldn't be a discussion about mental health in the workplace. I mean, when I started practicing law, the prevailing ideology is life is tough, get a helmet. right? You gotta move through, push through, and if you're not performing, you're going to be in trouble and you're going to be on your way out. Now, that's a kind of a blunt instrument, but it's one that's been used, and there's still a prevailing ideology in the workplace. And I'm going to say there's still room for that every once in a while. All right? There's room for that where there is no connection between the mental illness and the performance issues or the misconduct. We're going to talk about that in a second. This is what I want to focus on right now, particularly from an employment perspective. And we're all employees. Some of us are managers, supervisors. We all have responsibilities to other people in our lives. But it is protected from a legal perspective where there is a causal connection between the misconduct or the behavior and a mental illness. So if there's a connection between the mental illness and the inappropriate behavior, I can use an example that in many cases, somebody who is suffering from bipolar disorder isn't on their meds, acts up in the workplace, often is perceived to be violent. That is a misconduct in the workplace, which under normal circumstances might be meritorious of discipline. But if it's connected to that mental illness, it's a disability. And employers need to treat it like a disability. What does that mean at law? You need to accommodate to the point of undue hardship, right? If there is no causal connection, and I'm only going to refer to one case that actually demonstrates this pretty well, then it's just misconduct. You're not a performer. You're not being a good employee. You did something stupid. You punched a coworker. Whatever you did, all right, that then is disciplinable and can lead to discharge. But if there's that connection there, it's no different than saying, and the bit where it really comes up is in attendance issues, and whether or not you can manage somebody's attendance differently than if they're off Fridays and Mondays, that might be one thing, right? But if they're off because they have a disability, they have mental health issues, that's a completely different thing which requires accommodation. You wouldn't say to somebody who's suffering from cancer or a heart condition, your absenteeism is bad, we got to fire you, right? You got to change the approach. This is frustrating for employers, and I get it, because it's difficult to manage a workplace where you have somebody bringing a note that says, I'm off for 6 weeks, I'm off for 4 weeks, I can't do my job, right? It's hard to rein in. There's some diligence required, and we're going to go through that in a little bit, but what we really need to understand that unless employers start to understand that we will be deemed to have knowledge of certain conditions if the red flags are there. All right, constructive knowledge, which is a legal concept now. It's what the objective person would look at. If there's constructive knowledge of a disability, then an employer is deemed to have knowledge. If you should have thought, if you ought to have known, then you have to deal with it as a disability, and that's very different than a traditional approach, which is we're not asking any questions, we're not looking any deeper than the conduct or the misconduct at issue. Right? If we've got some of these factors. A previous disclosure. What kind of medical information do we have on file to understand if they've had previous problems? Are there statements? Is there absenteeism, their conduct towards other employees? Is that all of a sudden started to flare up? Those are red flags. Now, what that doesn't mean is that you can go look in their profile and find out everything about them. What it does mean is you may have to ask some questions as to whether or not the employee needs assistance or whether there's that connection between that conduct, the performance, right, and any mental health disability. There's some kind of signals, some red flags. Now, when that occurs, the issue becomes for an employer, well, how deep do you delve, and what can you do about it? The biggest issue we're having right now, and this is kind of not going to surprise anybody, but performance management. As soon as you sit down with somebody for performance management, the bigger the awareness, the more employees are going to be aware, good and bad, that this can be used to their advantage or to their disadvantage. So a performance management issue comes up, you sit down with the employee says, I'm going home, I'm suffering from stress. The stress arises from the performance management. The employer says, you got to be kidding me. You're off because I asked you to do your job, right? That's when everything falls down, because all of a sudden now you're trying to manage somebody who may or may not have a disability, you're not sure, but you've just performance managed them and now they're off work, all right? So when there is a disability that is related to that, and that is asking the right questions, there's a whole element of being able to ask for the appropriate medical to determine whether or not there are any issues that the employee suffers from. That is perfectly legal, perfectly reasonable, and quite frankly, is required in the law of accommodation. An employer does not know how to accommodate unless they know what they have to accommodate. This does not mean asking for a diagnosis. All right? We don't do that. What you can ask is, are there restrictions arising from that mental health disability that we need to know about so we can look to whether or not we can accommodate them in their employment? That's the whole idea of accommodation. It exists whether or not you're a worker at GM and you can't bend to the line because your back hurts, or you have a mental health disability, which means that you can't work certain shifts because it impacts your mental well-being. It's the same concept. It's way harder to apply with kind of the unknown disease, right? The issue becomes, we don't see it, we can't deal with it, we leave it alone, all right? That's accommodation at law. Now, there is a big, one of these things is not like the other, and that's compromised worker and workplace safety, right? We do know one thing, and the law treats safety issues much differently than any of these other issues. And you have to accommodate to the point of undue hardship unless you got one of these or a combination of these. I will tell you, most of them all put together don't mean anything. The tribunal is going to find that duty is so high that employers are very, very rarely can meet it if they just put financial cost, for example. Safety is a different issue, and we've seen this in the cannabis cases. We've seen this in cases where people are in safety-sensitive positions. If they cannot work safely because of their disability, if that arises as a result of a substance abuse disorder, for example, right, there is not necessarily an obligation to put them back in that position. Doesn't end the obligation to accommodate, but it means that you don't have to put somebody who has a substance abuse problem behind a loader when they're working on the tar sands in Alberta. But there still is a question of accommodation. So you must accommodate to the point of undue hardship. You must also understand that it's a multi-person inquiry. This is what employers have to do. You got to accommodate, so there are substantive and there are procedural duties. And I'm not going to bore you with the law stuff, except to say that procedurally you have to look, and you have to show that you looked in the right places. Substantively, you got to implement when you find. And that may not mean, well, you can't do all of your jobs, so we don't have a job for you. That's not the way this game works. You have to accommodate, and it can mean by giving them duties temporarily, usually. There's no obligation to create a job for employees, but duties which will accommodate them in their job to try to assist them to get back to full duties. There are going to be employees who can never be accommodated fully to get back to their job. The question of accommodation on an ongoing basis then becomes a legal one. All right? I want to talk a little bit specifically about mental illness because it does deal specifically with substance use disorders. There are three big things that employers need to know about this. One is elements of denial. Second is constructive knowledge, which we've talked a little bit. And the third is subjective fears. So this is a pretty good quote from a Canadian human rights case that came out many years ago. And it talks about, if I can look at the last couple sentences, psychiatric disabilities have many possible causes, sometimes physical, sometimes psychological, sometimes social. Such illnesses are shameful and embarrassing for many people, and as a result, they are very reticent to stand up for their rights or protest when injustice has been done to them. So that is a symptom, all right, of substance abuse or alcohol abuse. People will not admit this. They find it shameful, even now, with a heightened awareness of mental disability at the workplace. They are not going to come forward right away. And that becomes an issue, because we have to accept two things when it comes to employees who suffer from these kind of disabilities. Number one is you're not going to hear about it right away, probably because they're thinking that they can manage it. And there's going to be a crash, and you mentioned, Dr. Wyman mentioned that meltdown at work, where it's a minor thing and things blow up. An employer's initial reaction may be, well, fire the person, they did something crazy, or discipline them, or get them out of the workplace, but that's a culmination of factors. So that's one thing. And the second thing you have to accept is recidivism. It's going to happen again. It often does. And you cannot... The law does recognize when an employer will get to a point and say, you know what, hands up, no mas, throw in the white flag in, there's nothing else we can do. And the law will recognize that. But you got to accommodate to that point. All right? So understand as an employer that there are going to be denial issues when it comes to these kinds of issues. Right? That's another. If you ever want to know, by the way, where case law is going, you always look at labor arbitration cases because they get decided way ahead of court cases on any issues that are important. Whether it be accommodation, cannabis in the workplace, all of the big cases right away are all labor arbitration cases. But this does speak to the issue of something being so obvious that you don't need to be an expert to figure them out. If you turn a blind eye to it as an employer, you risk that if you terminate or you discipline, that employee will raise the issue of the termination or discipline being based on a disability. So I had a case a number of years ago where the individual was convinced he was accommodated to a permanent daytime shift because he said he couldn't work the nighttime and the afternoon and evening shifts. He was a 2-year maintenance mechanic. The lowest seniority in that department that got day shift was 25 years. So as a result of the accommodation, his mental impairment was that he believed that there were people on the afternoon shift who were going to kill him. All right? So we knew that wasn't the case. We did an investigation, and then those people ultimately left. But he still said he required the daytime shift accommodation. Now, the employer couldn't figure that out right away because it's a subjective fear. Ultimately, when I cross-examined the doctor, he said, that's what he told me. So the employer says, well, wait, he told you that, and that's what we got to do this for? It doesn't make a lot of sense, which heightens the importance of understanding and getting the proper medical information at the proper time before you make those decisions. Subjective fears are real. Managing them is more difficult, but they can be managed. All right? Ultimately, he was put on a shift because of physical disabilities, not the day shift, but on an afternoon shift where he could have access to better treatment, and that helped. One quick case on constructive knowledge. This is a good one, and it's very recent. This is somebody, most employers will recognize this, somebody terminated after twice calling in sick during her first 4 days of employment. That's not a good employment record. You haven't 4 days and you're gone 50% of the time. So they checked the references and they found out she did it before. So there's a little bit of a pattern here. She said, I got a mental disability. You're discriminating against me. I've got depression, anxiety, post-traumatic stress disorder, and insomnia. And the employer failed to investigate. To investigate after 4 days, 2 of which she wasn't there. That's what she indicates as the proper standard. And the employer said, well, you never disclosed. We can't investigate. We can't understand what we don't know, right? So, interestingly, the tribunal said her anxiety and depression constitute a legitimate disability. No argument. As a matter of fact, I don't believe that the employer even took issue with that. What they did say, though, is that the employer didn't know or ought reasonably to have known that they had the disability, right? All of the symptoms that she had nothing to do with what would typically be understood to be anxiety or depression. She just seemed like she was sick. She was calling in sick, right? So it didn't trigger the constructive knowledge portion of that, and therefore they weren't discriminating on the basis of a disability because they didn't know. You can't discriminate on the basis of something that you don't understand, and you can see what the symptoms were. So there was no duty to inquire, and that was really what the issue was. When does that duty trigger? And that changes for every employee, right? That's very important. And there's one good quote here, and this will be music to the ears of most employers, because she alleged reprisal as well for now saying that she had a mental disability, and that was the reason. And she said at the very end, good line, and I think this makes sense both legally and practically. The fact that the investigation caused the employee to feel bullied and embarrassed is not evidence that it was done with the intention of retaliating against her for claiming and enforcing her rights under the code. All right? That's a big distinction. So now we got 2 roads. Employers understand this, right? We talked a little bit about subjective fears, but employers understand this. There may be a disability, there may not. All right? If it's a disability, we go down the accommodation road. If it's not, we can go down the discipline road. That seems pretty clear, right? We're all okay with that. The problem is they often intersect. So you may have somebody who has a legitimate disability, and part of their misconduct, for a perfect example is an employee who may have a mental health disability, who may have a substance use disorder, for example, but takes Fridays and Mondays off in the summer, right? Those Fridays and Mondays are probably not medically supported, right? But they do have a legitimate disability. So how do you clarify them? Well, you clarify them by asking for information, getting a doctor to kind of give the restrictions, and where appropriate, challenging those restrictions, right? It is hard as hell. I'm going to tell you. Put my kids through school. This is the biggest stuff that comes across my desk every day. How do we do this? Like literally this morning at 7:30, I got a call, right? Guy's not doing his job now. He says, I got a condition, right? What do we do now? We start from the beginning. And that's how it works. And it's frustrating, but the better your process, right, the better off you are in terms of dealing with the legal liability and defending yourself. Have a good process. Employees are better with it. The law is better with it. All right? I want to talk a little bit about recreational cannabis use, because everybody freaked out about this. You remember last year when this was coming, it was the end of the world. I used to ask employers, particularly American employers, they would say, well, we got to have drug testing. We got to have there's cannabis in the workplace. How do we stop cannabis? And I'd ask, well, do you test everybody who has for drinking when they come in the workplace? Well, why would you do it for cannabis? Why is that any different? Right? It's an impairment issue. You're either impaired or you're not. You can't be impaired. I don't care if you suck on balloons and get helium. You can't be impaired at work. All right? End of story. That's your policy. Now, if you have an addiction, you got to accommodate it. All right? But recreational use of cannabis is not a disability. You can discipline somebody. You can keep them away from safety-sensitive positions if it's recreationally used. All right? So, we need, for an addiction, we require disclosure. We need to understand the addiction process, when the return to work is, and whether or not, and we can insist, by the way, at work that there's abstinence in future use. Because you can't come to work impaired. Now, we have to build in that whole recidivism, that reuse issue. But for medicinal, it's a full accommodation issue. But that doesn't mean I can spark one up in the lunchroom. All right? You can't do that either. All right? There are people who tried that, believe me. I got lots of cases like that. But what that means is that it's not their chosen use, but if it's a medicinal issue, you accommodate it as if anybody had another, like a bad back. How would you accommodate that? You'd look at the restrictions, you would do it. So you have to go through that inquiry. And safety issues are very, very important. I did a case a number of years ago where a person at a manufacturing facility who had bipolar disorder did not disclose it. We did 3 work trials. We ultimately got some medical on it. But he kept on turning machines on and off randomly, so there might have been people around. He slapped a coworker in the face with a glove, and he tore the crotch out of his overalls. Right? Not a good look in a manufacturing facility, I can tell you. Right? And what that meant is that the employer kept on sending him home and saying, you need to be on disability. The union said, no, he wants 100% of his full wages. So we went to arbitration, and the arbitrator said, I'm not looking at accommodation if it's a safety issue. Full stop. That's what we need to remember about this. All right? So this is the advice I always give to employers. Do a risk assessment. Relax. Okay? Everybody wants to fire right away. Not everybody. Berlis doesn't do that. But everybody wants to take the immediate reaction is discipline, terminate. You got to step back, because it's going to cost you a lot of money down the road if you make the wrong decision, and it's not great for the workplace. So do the assessment, recognize the signs. If there are employees who look like they need, offer assistance, even if you don't know. Bring them in, say, we have an EAP program, you're struggling a little bit. All right, we need to talk to you about it. Here's what we got, it's anonymous. We're not going to press you on this. Take a look. We encourage you to use it if you need it. First step. Really good first step by employers. All right? Consider the alternatives. Sometimes discipline is not the answer. Sometimes it means moving them around. Sometimes it may be a disagreement with an employee that is heightened by a mental health problem. Right? So figure out alternative solutions before you discipline or terminate. Right? And medical information is absolutely critical. You cannot do this stuff without knowing where the fences are. You can't manage without understanding what you got to manage. Right? It doesn't work. So unless we're going to do it that way, and I'm going to leave that now. But unless you do it with a kind of a holistic view on this, and I'm just going to echo Dr. Wyman's comments about, we could do a whole kind of webinar on things in the workplace that you can do to kind of alleviate that distress for employees. right? We've done many of them here. We have a program every year that we visit, and I think you're starting to see more employers see not just the benefit to its employees from a morale perspective, but from a productivity issue, right? If you've got employees who are more stable and happier in their work, productivity goes up. There's a direct correlation between those two. So finding ways to do that, finding ways to address issues early, finding ways to manage them in a more comprehensive and humane way is going to reap benefits. There are times for discipline. There are times for termination. We know those times, but we've got to discover how to put a process in place where we can make sure that we've got them. So those are all my comments on the job stuff. Andrea?
Thanks, Lorenzo, and thank you, Dr. Wyman. So to start our discussion this morning, I wanted to ask both of you, if a colleague discloses to you that they're struggling with an alcohol or substance use disorder, what's the best way to support them, and what is the duty to report?
You want to go, Dr. Wyman?
Sure. I don't think I can speak to a duty to report outside of within the medical community. So we actually have a duty within our college if someone is being impaired to report to the college. But I think the best way to support them, and we talked a little bit about stigma, is to acknowledge the bravery and the honesty in reaching out for help, because that's a really huge step for someone to take. You can imagine that it's probably taken them a long time to get the nerve up to do that. And it may be, as we've said, because something has really hit rock bottom in their lives. So trying to convey understanding and compassion and lack of judgment, and then offering to be a resource. You don't have to be the caregiver. You can just help them maybe problem solve. I would always tell someone to go to their family doctor. I think, primary care is sort of the medical home, and that's the place where people can begin that process. I've spoken a little bit about the fact that not all family physicians necessarily feel really sort of well prepared to manage those issues, but there are lots of resources that they can work with.
I'd fire them both. I'm just kidding. I'm kidding. All right, edit that one. Look, I think I agree with all that. I think having a workplace where there is a concern in a workplace that people are snitching or telling on people or disclosing information which they're concerned about as being private. The privacy issue here, I think, is a bit overblown, but I think it's a concern for employers. I don't want my personal information, or I don't want to tell information about other people. The analogy I would use is way back when sexual harassment became an issue in the workplace, people were very afraid to report about what they saw other people experiencing. All right? We're now in a position where that is not as much of an issue, and that's come through education, through the legal system, all of that, right? So I think we're evolving towards that, where we encourage employees that if they see somebody struggling, number one, they can report that on an anonymous basis, like to an employer. But for the individual themselves to have the resource available where they know they can go, particularly on an anonymous basis. Because I think that's a big part of it, I would say, in all workplaces, not whether it's manufacturing or an office environment, having that ability to move there. But I think you need to encourage employees who see other employees struggling to bring that to the attention of the employer without worry, so that the employer can see that red flag and then maybe offer the appropriate assistance.
And that gets back to your comments, Dr. Wyman, about fostering a culture that is conducive to sharing that information. So maybe this is a question more for you, Dr. Wyman. How do you differentiate between depression and, say, work stress or lifestyle choices that might appear to or contribute to one being sad or depressed or just not themselves?
I feel like that's a bit of a loaded question. I think we spoke a little bit about the layers to try to give a sense of some of the complexity. I would say, I've talked about a continuum or a spectrum, and I would say there's a continuum in terms of mental health disorders as well, from, what we talk about in terms of anxiety or depression. Lots of people struggle with some anxiety. That's not necessarily the same as a profound disabling anxiety disorder or mood disorder. I think that sometimes people make bad choices. All of us can do that, whether we're influenced by substances or not. But when it comes to sort of the net impact overall, we can use the various tools that we have to try to determine whether there's an actual diagnosis, and I think Lorenzo spoke to that, right? Do they meet the criteria for depression? Do they meet the criteria for substance use disorder? And then how are we going to work with that to help that person make better choices? So sometimes their choices are part of the diagnosis in and of itself, right? So we talked about compulsive use leading people to do things that really don't make any sense, or being intoxicated and making choices that then have some pretty severe consequences overall. So it is messy. It can be a little bit hard to tease out overall. And certainly when someone is using and withdrawing actively, it can be very hard to separate those symptoms from the symptom of the underlying mental health disorder, and it can take time. So I think that speaks to what you spoke about also in terms of trying to make sure that they're getting a proper assessment, that they're getting special care, not reacting in the moment and then putting yourself in a position that you might regret afterwards.
Yeah, I think, so within the workplace, the legal obligations collide with the obligations that you want to being good to the employee and trying to create a culture in the workplace which accepts those issues. But the law does recognize that you get to a point where there's a frustration of contract, where even if the employee is being accommodated, if there are continual relapses, or if they simply cannot perform the duties of their job, even with accommodation, or they're in a position where they have now been, their condition makes it impossible for to do even modified duties. You can take the position that the employment has been frustrated, right? It's a complex and a very difficult legal issue from an employment perspective, because you really are saying that you've accommodated to the point of undue hardship, and now you're taking that position. But you're allowed to, all right? And employers don't have to continue to employ people who simply can't do the work. Now, there are disability policies for that, right? The question becomes after a period of disability, and particularly we don't recommend that there are any terminations if they're on long-term disability until after the definition changes under the insurance policy from own occupation to any occupation. But those are issues that you look at legally. But at some point, the employer says, and there's a question here that I just read about, an individual who's probably gone back 4, 5, 6 times and gone to rehab, come back, drop back into their addiction all 4 or 5 times. Well, there's a point, and the law recognizes, where you're going to say, look, we just can't do this anymore. And the law will recognize that. I think we want to make sure, aside from protecting from liability, we want to make sure that you've done the right thing for the employee in terms of giving the right medical, disability, and resources.
Yeah, and I don't mean to suggest that we should absolve people of responsibility because they have a chronic condition. I think it means having a different lens and recognizing that sometimes their choices are impacted by their perspective, by their illness, and that even when people are trying to make choices, sometimes they face a lot of barriers in their recovery.
Okay, we have had a number of questions come in, so...
Got a whole pile here.
Yeah,
there you go.
So
those are yours.
So, Lorenzo, one question that came in was, if an employee is requesting a leave of absence due to stress, is it a WSIB claim or a short-term disability? How is the employer to treat that?
So, arguably, if it's a workplace-related stress, right? If it has to do with something that occurred in the workplace, that's covered by the WSIA, the Workplace Safety and Insurance Act. And it would be a claim to them, and the board would make a determination as to whether or not they get benefits, right? If it's not, and I would say that probably most stresses are a combination of things rather than just one, then it would go through your regular short-term disability, a carrier if there is short-term disability, or EI if there isn't. But it's not, there's some benefits to it going under the WSIA. For example, it removes the right to sue the employer, So if somebody, that is a complete and a total legislative response to injuries at the workplace. So if somebody is under that legislation, they can't sue you for wrongful or constructive dismissal, or they can still bring a human rights complaint, because it deals with all those issues arising from that. And stress is relatively new to that piece of legislation, right? Otherwise, it's a short-term disability issue, which has to either be, if they're ASO, if the employer is self-insured or has an administrative services only agreement with the insurer, it will be adjudicated, and then benefits would be provided based on whether or not they, usually STDs are pretty much rubber stamps if you're going on short-term disability. Long-term disability is a lot harder to get, but on short-term disability it's easier, and that's actually when people with these types of issues in particular can get the most assistance, because they have that 26-week period usually where you can get them assistance, where if they're going to be off work, they're receiving pretty much their full salary, and they can get some help.
I'm just gonna jump into the questions so we can address as many as possible. So Dr. Wyman, there's a question here about, you mentioned the medications that can be used to assist with withdrawal symptoms, and there's a question about how effective those medications are typically and whether there are adverse side effects.
So I'll speak about alcohol and opioids separately. The medications that we use for treating alcohol withdrawal are typically what we call benzodiazepines. That's the Valium type medications. They definitely can cause side effects in terms of sedation. They should not be used on a long-term basis. So no one should be on long-term Valium to treat alcohol withdrawal. It should be stopped after anywhere between 2 and 5 days. However, what we call milder or subacute withdrawals can go on for a long time. There's another category of medications that we use for that. And if those are causing impairment, then the dose is too high and they should be cut back overall. With respect to opioids, it's a bit different because we use medications, typically buprenorphine, which is also called Suboxone or methadone, on a much longer term basis to try to really help people stabilize, so those treat withdrawals, thereby helping people to reduce their use. So that's typically considered long-term treatment. Those medications can cause sedation. But again, I would argue that if they do, then the dose needs to be adjusted and brought down. And I know that that is particularly an issue in terms of safety-sensitive workplaces and with regard to methadone. Suboxone is a much safer medication. It has much lower risks of sedation and of side effects. And people can work and be stable and completely functional on that medication. Many people can work on methadone. I have truck drivers who are on methadone. I would say that the individual I always think about is at much greater risk from his drinking than from his methadone. But methadone does have greater risks and needs to be monitored carefully. But again, there are many people who can work. And if they are sedated, then their treatment needs to be reassessed.
Okay, great. That's helpful. There's a question about how a company deals with non-substance addictions, like internet or pornography or video game.
Oh, there's a whole different topic there.
And I recognize that, but I wonder.
No, it's actually a good question, I think.
If you could speak to that.
So, 20 years ago, there were a bunch of these cases, right? There was the internet porn cases, right? A ton of those in the employment, particularly in the labor side, people who were addicted. I actually think the approach is the same. And for an employee who has been terminated or gets disciplined because of that kind of misconduct, if it's a medical issue, my view is then you need to give support that's a medical issue for you. And there is lots of contrary law on that, and I think probably contrary medical opinion on that. But the bottom line is the calculus is the same in terms of, from an employer's perspective, how you deal with it, which is if that's a condition that you're saying caused this, there's a causal connection between your misconduct and what you say, then that's a problem. It's not as easy as, like there's a famous case that came out about 7 years ago about a nurse who was stealing narcotics from the hospital. So she had the key to the cabinet, she was stealing it, and they terminated her when they discovered she lied about it, and they terminated her. And at the arbitration, the arbitrator said, look, that's theft, you're gone, but the reason she was stealing, all right, was because of her addiction. So he made the connection. Now, what he didn't think about was safety. She was dealing with patients every day. She was using while she was at work. That wasn't considered in the decision. I think that was a downfall. But he made the arbitrator made the causal connection between, look, she wasn't doing this on her own. She was being driven by an addiction. That's why there was the theft. When I look at other, like there was there was other theft cases, money from a till or whatever, where the individual said, I have a drug addiction. And the arbitrator came to the exact opposite conclusion and say, I haven't found that that was the driving reason why they had to go in and pick up the money. That was a conscious decision that had nothing to do with their addiction. There's also the complicators about people, for example, who are perfectly fine on medication but choose not to go on the medication, whether that's a culpable act, whether that means that they can now be disciplined because they've popped off the medication voluntarily. And that's a big issue, particularly with people who are on medication that has side effects. They don't like them. They think they're fine. They can finally go off them. They go off them and they get into trouble. And then the decision is that a decision? Is that culpable? Can we discipline you? So I think it's a bit different. I would put that in a different category, but I think the approach for employers is the same.
Can I just make two quick points?
Yes.
One is that from a treatment perspective, the resources are really limited when it comes to treating behavioral addictions, whether it's internet, porn, gambling, etc. The other, I think, is, it behooves us to think again about that notion of the continuum and our own behaviors, right? And our own attachments to behaviors that might not be so healthy. Our phones, for example, and when that becomes an addiction, when we can turn it off, when we can't, and detach. And again, just kind of, there are those out there cases where clearly, someone has a serious problem, but for some of us, it could be sort of a there, but for the grace of God, right?
And so just dealing with other sort of addiction type matters, Lorenzo's presentation touched on cannabis, and I wondered, Dr. Wyman, if you had anything to comment on or have a perspective on whether cannabis is addictive or can be addictive. Can it be a substance use disorder, and in what circumstances might it be?
We could spend a long time talking about cannabis. The short answer is that only a very small proportion of people who use cannabis go on to develop cannabis use disorder, but yes, it is possible to develop addiction. And there is, when we think about addiction, again, we think about those 4 C's, so loss of control, compulsive use, consequences. There are withdrawal symptoms when people use on a long-term habitual basis, nausea and anxiety. Of course, one of the problems is that people feel that when they use the cannabis again, their anxiety goes away. So they think it's the cannabis treating anxiety, not recognizing that the anxiety can be a withdrawal symptom from the chronic use overall. The big messages, I guess I would like to sort of get in there overall. Lots and lots of youth start cannabis and use and never go on to develop disorder. Probably the odds are about 1 in 8 of people using to develop a cannabis use disorder, and the complications are associated with starting younger and more intensive use, so using daily or almost daily in high doses, especially those starting under age 18. And of course, we encourage people ideally not to use while the frontal lobe, the part of our brains that are responsible for all our really complex thinking, are developing, which is up till age 25 overall. But many people will smoke and use really heavily and then just stop at a certain point, and recreational use does not equate to cannabis use disorder by any means, much in the way that people will drink, and drink in irresponsible or unhealthy ways in their younger years, and then drink in more moderate and responsible ways later on in life.
It's an interesting intersection now between how we look at cannabis, how we looked at alcohol, how we looked at painkillers in the workplace. There wasn't a lot of thought given to that at the years ago, where I can tell you almost certainly there were many, you had truck drivers, you had loader operators, you probably had pilots who were on painkillers and all kinds of other things that were probably much more harmful than cannabis. But employers now are starting to understand the difference about intoxication. Rather than just what they're using. So I think that's an important distinction. And internally, employers who have policies about what they can have and have at work, I like that example about having access to alcohol at a big party. Well, that is difficult for some people, but it's also creates not only a social host liability, but liability within, like if you have our eldest son is a creative guy, and one of their big clients is a cannabis company. And the first time they met them, they brought a bag of weed, like a backpack of weed, into the boardroom, right, and threw it on the boardroom. This was before it was legalized. But everybody at the office and everybody at that place uses, and they use during work. And I said at one point, well, what if one of these people goes off, what if one of your employees drives off the road after smoking a fatty at work? What's going to happen? That's no different than giving them a jug of gin and saying that's okay if you drink it at lunch, right? And these are things that are dawning on. It's going to create a whole different set of rules that I think we have to look at consistently between all substances that can create intoxication, not just one.
Are there questions from the audience? If there are, just raise your hand and we can take them. Jessica.
A question about the cannabis. Now that for chronic pain, for arthritis, osteoporosis, and whatever, they have now medication that they use cannabis products. So you said it's not addictive? Anything?
Well,
So if I could just say, so the question is around the fact that there are now cannabis-related medicines, effectively,
Right.
for the treatment of chronic conditions and those sorts of things.
so there's an industry developing, right? I mean, where there's a void, it will be filled. I think I want to say two things to your question. So one, is it addictive? When used as prescribed or as authorized, because they're not actually prescription medications, right? You can, in fact, buy the same combinations of THC and CBD products at an Ontario cannabis store as your doctor can authorize. There's not really a specific type or brand that specifically needs authorization to access. So when they're used appropriately in the right concentrations and dosages, no, they shouldn't be addicting, but you still need to be careful around sedation. But the bigger point that I want to make is that there is actually very, very poor evidence that cannabis-based products are effective for chronic pain. And within the medical world, the one true indication is for something called neuropathic pain. So that's burning nerve pain, like people have after shingles, for example, or with chronic diabetes. When people have tried and not been successful with 3 traditional medications, that's the only actual approved indication for a cannabinoid for chronic pain, except for very rare situations. There are some chronic intractable seizure disorders that have some evidence as well. So this industry sort of marketing CBD or THC products, whether it's for pain, for anxiety, for your broken toenail, for your whatever, is unregulated and very problematic from my perspective.
Question in the corner.
My question is, what is considered recreational use? So we have with alcohol so many drinks a day, so many a week. When it comes to marijuana, what is deemed to be recreational before it's considered addiction?
It's a great.
So the question is, what is recreational use for the purposes of marijuana or cannabis?
So there actually is a set of guidelines that was produced by the Center for Addiction and Mental Health, trying to sort of compare to the low-risk drinking guidelines. It's much more complicated because historically we haven't been able to really track how people are using because of all of the criminalization issues. It's also more complicated because there are so many different strengths of cannabis products. There are different proportions of the THC and CBD. How people use the product makes a difference in terms of smoking, vaping, or edibles. The individual variability in terms of how they respond to those products is different. So I would bring it back to those principles about, are they using in a controlled way? Is it impacting their function overall? And I think what the guidelines would say is that daily or near daily use is problematic. using when it interferes with work, or, just as Lorenzo said, a gin on your way to work in the morning, So, smoking your joint in the park before you walk in, so having issues being able to control that in any way, feeling like use is escalating or feeling withdrawal symptoms are all signs of problematic use. So using in a social way, weekends with friends, late at night to fall asleep, but any time that it's becoming something that is ritualized, habitual, using on a daily basis without stopping to kind of consider the implications, is starting to veer into that problematic territory.
From an employer's perspective, if the individual is not asking for accommodation because they say it's medically required, that's recreational. That's the bright line from an employer's perspective. Unless they're saying, I need this, I've got it medically prescribed, I've got the little certificate, then we consider it recreational, and there are lots of issues arising from that. But that's the brighter line test from an employment perspective. Sorry, go ahead. So the one thing I do, because I saw another question on this that before we go, and we're almost done, is the employer's concern with stress in the workplace because they don't understand what's going on with the employee, and then their inability to perform the duties of their job, or just going off because they have stress, which may or may not be related to some kind of substance use. This is the toughest one because stress can come from a lot of different things. Sometimes stress can be a good thing. But managing that within the workplace for somebody who, and I made reference to this earlier on, somebody who sits down and says, I'm suffering from anxiety, I'm suffering from stress as a result of the workplace, that's one issue, because that might be a factor within the workplace. I think that makes it a bit easier to investigate and say, well, what are the stressors in the workplace that we can assist you with? If it's somebody who just has an overall issue with respect to stress, anxiety, then you treat that as a medical condition. The problem is, and I'm not throwing stones at the medical profession here, but we get notes, and the note is, can't work until 3 weeks. We'll be seen again in 3 weeks. And that's all you get, right? And that's really frustrating for employers, because they don't know how to accommodate that. They will say, I got work for you. What can we do, right? Stress, and I think that a recent case I think it did have to do with an addiction, but it was a senior executive in a big company, and his restriction on accommodation was stay away from stress, right? Right? Like that's like telling a truck driver to stay away from the road. It ain't going to work, right? So you got to take a different approach on that. You got to say, we just don't have work for you on that basis. But that's a decision that's after accommodation. So just to go back, because we've been talking a lot about the addiction issues, that really does make it more important that you understand from the front end what you got, rather than waiting till the end and looking backwards. So.
Dr. Wyman, do you have any perspective or comments to share on the topic of physician notes in support of a disability or an alcohol use disorder, for example?
That's a good question.
Yeah, I think I just want to share that we're really not well trained in thinking about what employers are looking for. And the other thing is, to recognize that we're sort of walking a bit of a tough line, right? Because we want to be providing good care. We need to be advocates for our patients. We're not trying to misuse the system on their behalf, but we're trying to really help them. And we also, at some times, really only have their own self-reports to go by, right? I think you've said a lot of this area is much more subjective. It's not like a blood sugar reading or a blood pressure reading where we know what our target is, we know what the medication is, and then we kind of move on from there. So I would say if you're getting notes back that are unhelpful, try to provide some specific questions and guidance. I think that would go a long way. And there's another topic for a webinar.
Absolutely. I think we got one coming up. Stay tuned, folks. But I asked specifically, I will tell employers, send the job description to the employee and tell them to give it to the doctor. This is exactly what the employee does, right? What can't they do? We need to know. If we're going to accommodate, that's what the law says we got to do, right? What do we got to do? And that's the real issue, is you've got to be specific about what you're asking for, not diagnosis. Don't want the diagnosis. But you want to ask, If you had somebody who said, I can't work because I can't bend down to the line if I'm working manufacturing, you would say, well, can you fill out this functional abilities form that says can't lift more than 7 pounds, can't walk more, can't do more than 15 steps. You would get all of that, but we don't do it for the other stuff, but we have to. This is the job, what can you do? And if you can't, can you explain how that works within the context of their disability? Because I need to understand that if I'm putting them back to work, both safely and to get them to do productive employment. I don't think those are opposed issues. I think we just got to work better on that, because that's the big frustration. And quite frankly, given that you can't see a doctor or a specialist for months and months in Ontario, you could have an employee who says, I'm waiting to see my specialist. They're off for 4 months, right?
And paperwork will always be sort of at the bottom of our pile compared to clinical care, right? And so it's nobody's favorite thing, and when you're going to get to it. So I appreciate that frustration, though.
And Lorenzo, maybe just one final question. Is there an important distinction or not between, say, a doctor's note from a family physician versus a specialist?
There is if ultimately it's a condition which I think is specific and needs specific treatment by a specialist. So if a family doctor says, look, they're just depressed, right? That doesn't suggest that there's an ongoing issue unless you start getting recurring notes. It may be that the employer wants to get an independent medical examination to go deeper than that general note. I think there is the short answer. I think there really is, because if you get it from a specialist, I think it's a more focused assessment and gives you more information than you would otherwise get from a family doctor who may not be specialized to deal with that condition. So I think absolutely. So
I think we're at about time. So thank you very much, everyone, for listening. Just a reminder, the presentation material and the HRPA code will be emailed to you within about a week. We have an upcoming webinar on power of attorney, which you can register for by clicking on the resource section on your webinar screen. And just before we sign off, I want to thank our technological support, Richard and our IT department, as well as our marketing department, for organizing this webinar. And thank you very much again, Dr. Wyman and Lorenzo, for your time.